Well, I want to thank the organizers for the invitation to speak today. I really wish I could be there in person, but I've really enjoyed all of the talks so far. So as was just described, my lab is primarily a bioengineering lab, and we focus really heavily on developing predominantly fibrin targeting strategies to augment bleeding after trauma or in wound healing, or to develop antithrombotic materials. But we've also had an interest in characterizing fibrin properties, particularly with regards to fibrin structure, mechanics, and degradation in various disease states, as well as a function of age. And so what I'm going to talk about today is some of our recent work where we've been working towards identifying age-dependent differences in clotting, specifically during the neonatal period, and how this can have implications in treating bleeding in the neonatal population. So the hemostatic system is immature at birth, and it matures through the first year of life. There have been extensive differences noted in hemostasis between adults and neonates. And neonates are babies that are less than 30 days of age. These differences include the existence of hyporeactive platelets, decreased clotting factor concentrations, slower thrombin clotting times, as well as numerous biochemical differences in clotting proteins, including most notably fibrinogen. In neonates that have congenital heart disease that require cardiac surgery within the first few days of life, this hemostatic immaturity can place these babies at high risk for postoperative bleeding and or thrombosis. And this is a major problem because congenital heart defects are the most common birth defect, and up to 25% of infants that have congenital heart defects will require cardiac corrective surgery within the first few days or weeks after life. And these surgeries require the use of cardiopulmonary bypass. Bleeding, of course, is a common complication of cardiopulmonary bypass, or CPB, and this bleeding complication occurs both in adults and neonates. However, neonates in particular are especially prone to post-CPB bleeding, and this is due to the massive dilution of coagulation factors from the CPB prime, and it's also due to extensive suture lines that are associated with complex cardiac corrective surgery. And finally, of course, their immature coagulation systems contribute to post-CPB bleeding in neonates. Therefore, bleeding after cardiopulmonary bypass often has to be treated, and it can be associated with substantial morbidity and mortality in these neonates. Bleeding following CPB is typically addressed through the transfusion of adult blood products, and this can include red blood cells, platelets, as well as cryoprecipitate, which of course is highly concentrated adult fibrinogen. However, it's been noted that the use of cryoprecipitate has inconsistent efficacy in neonates, and often multiple transfusions are required to restore hemostasis in these patients. Additionally, increased transfusions are associated with multiple risk in this patient population, including thrombosis. And therefore, there's a critical need to reduce transfusion requirements for neonates and determine safer and more effective methods for treating bleeding in this patient population. So this is something that we've been really interested in over the last several years. And to that end, in order to better understand how we've been really interested in better understanding how hemostatic immaturity influences neonatal fibrin network properties during the course of cardiopulmonary bypass, as well as post-CPB in the presence and absence of various procoagulant factors. And although transfusion of adult blood products to pediatric patients is performed routinely to control blood loss, reduction in the usage of transfused blood products has been shown to correlate with better patient outcomes. And as I just mentioned, it's been well documented clinically that the use of adult blood products does not consistently achieve hemostasis in these neonatal patients. However, the mechanism behind this lack of efficacy in the use of adult blood products in neonatal patients is not really well understood. And so several years ago, in collaboration with Nina Gazzetta, who is an anesthesiologist at Emory University and Children's Healthcare of Atlanta, we began to investigate the influence of cardiopulmonary bypass and transfusion of cryoprecipitate, which again is predominantly adult fibrinogen component. We began to investigate the influence of these factors on the structure of clots that were collected from patients, and we formed clots using patient-reported plasma, and then evaluated clot structure as well as some other features. But here we're evaluating clot structure using confocal microscopy. And as you can see in these images, cardiopulmonary bypass, shown here in this image in the middle, almost completely abrogates clot formation in these plasma samples. However, after transfusion of cryoprecipitate, we see a restoration of clot formation. However, we noticed in most of the patient samples that we evaluated, the clots that were formed were much denser and more heterogeneous than baseline neonatal only clots. And so based on these initial results, we hypothesized that neonatal and adult fibrin networks have distinct properties, and that adult and neonatal fibrinogen do not integrate seamlessly, which could potentially be leading to the observed lack of efficacy when giving neonates adult fibrinogen component. So today I'm going to focus on our recent investigations where we've been evaluating differences in neonatal and adult fibrin network properties, and again discuss the implications on treating post-CPB bleeding in neonates. And as I noted before, while there's many differences in neonatal clotting that have been identified in neonates compared to adults, we have predominantly been focusing on the role of fibrinogen in these clotting deficiencies. And of course, fibrinogen is the primary protein that's responsible for clot formation. Just to provide a little bit of information about the polymerization of fibrin, just a bit of a review here. So fibrin is formed following the cleavage of the fibrinopeptides A and B via thrombin from the central domain of the fibrinogen molecule. And this leads to exposure of the fibrin knobs, which can then go on to bind non-covalently to the A holes and B holes on adjacent fibrin or fibrinogen molecules. And this ultimately leads to the formation of an insoluble fibrin network that stops bleeding. This network also comprises the early provisional matrix that can serve as a scaffold for infiltrating cells in the early stages of healing. So in terms of differences between neonatal and adult fibrinogen and fibrin, it's been shown that the plasma concentration of neonatal and adult fibrinogen are approximately equivalent. However, it's been shown that neonatal fibrinogen has decreased clotting activity, an increased molecular weight, an increased sialic acid content, as well as an increased phosphorus content. And despite these previously reported differences, structural and biochemical differences between adult and neonatal fibrinogen had not previously been investigated in significant detail. And so in our previously published studies, we first investigated differences in structural and degradation properties in clots formed from purified adult and neonatal fibrinogen, or a mix of the two, simulating conditions of transfusion of cryoprecipitate to neonates post-cardiopulmonary bypass. And in these studies, we found that significant differences exist between adult and neonatal fibrin networks, which you can see here in these images. Specifically, we found that adult fibrin networks are dense and heavily cross-branched, while neonatal networks have much less branching, and they show a high degree of fiber alignment. Additionally, we found that neonatal networks degrade significantly faster than adult networks. And when we formed clots that were a mixture of adult and neonatal fibrinogen, we observed clots that had structures that were distinct from either adult or neonatal only clots. Additionally, it appeared that adult and neonatal fibrinogen did not integrate seamlessly. However, what we found to be quite interesting was that the clot degradation properties were actually more similar in the mixed clots to adult only clots. And these results indicate that transfusion of adult cryoprecipitate could potentially lead to decreased clot degradation rates, which could be contributing to increased thrombosis following cardiopulmonary bypass. And so we've been really interested in investigating this further and trying to understand what's contributing to these differences, so that way we can ultimately drive treatment strategies for these neonates. And as I mentioned earlier, there were early reports describing that neonatal fibrinogen has a higher sialic acid content than adult fibrinogen. And so we began to investigate this concept a bit more in the past few years. And so sialic acid is a 9-carbon backbone sugar unit that decorates the surfaces of many glycoproteins, including fibrinogen. And it's previously been shown in patients with liver disease that these patients have increased sialic acid content, which leads to slower clotting times compared to normal controls. And so there's certainly precedence that altered sialic acid content can alter clotting properties. And so we hypothesized that the differences in sialic acid content in neonatal fibrinogen could influence clot structure and polymerization mechanisms. And so the first thing that we did was to validate prior reports, and we analyzed the actual sialic acid content in neonatal fibrinogen. And what we saw is, similar to prior reports, we found that sialic acid content was almost doubled in neonatal fibrinogen compared to adult fibrinogen, with neonatal fibrinogen having approximately 6 nanomoles of sialic acid compared to approximately 3 nanomoles in adult fibrinogen. Next, we analyzed clot structure, again using confocal microscopy, either in normal fibrinogen samples or following cleavage of sialic acid from the fibrinogens using neuraminidase. And what you can see here is that the removal of sialic acid results in clot structures that are pretty similar between neonates and adults. And to us, this indicated that increased sialic acid may play a major role in the observed differences in neonatal and adult clot structure. And so we began to investigate this further through a number of studies. Here we began to evaluate the influence of sialic acid on polymerization, specifically using absorbance-based assays. And what you can see in the graph shown here is that desialated adult and neonatal fibrinogen have roughly equivalent polymerization patterns, and that they also have similar levels of maximum clot turbidities. And this is, of course, in stark contrast to the statistically significant differences that we see in both maximum turbidity and clotability in unmodified neonatal and adult clots. And so these results indicate that differential sialic acid content may at least partially explain functional differences between neonatal and adult clots. Next, we explored how fibrin polymerization mechanisms could further be impacted. And so to examine this, we started with normal neonatal fibrinogen or normal fibrinogen, and compared neonatal and adult clots that were formed either through the use of snake venom thrombin-like enzymes that preferentially cleave either the A or the B fibrinogen peptides, and then we compared those to thrombin controls, which cleave both the fibrinopeptide A and fibrinopeptides B. Specifically, we used batroxobin, which preferentially cleaves the fibrinopeptides A, contortrixobin, which preferentially cleaves fibrinopeptides B, or again, thrombin, which cleaves both. And then this allows us to potentially evaluate if there are differences in fibrinopeptide release and or interactions in neonatal fibrinogen compared to adult clots. And so these are results from confocal microscopy imaging that we took following producing the clots as I've described. And these structural results indicated that when polymerization is initiated with cleavage of only fibrinopeptide A with batroxobin, what you can see is that adult clots have significantly greater fiber densities compared to the neonatal only groups. However, we see the exact opposite when we drive polymerization with fibrinopeptide B cleavage, such that higher fiber density is observed in the neonatal samples compared to adults. Our thrombin controls are consistent with our previous studies, showing the differential structural patterns between adults and neonates. We also conducted functional characterization using clots produced either with thrombin, batroxovan, or contortrixovan, and we measured clotability. We also used atomic force microscopy to measure clot stiffness, and we also evaluated clot degradation. And what we saw in these studies is that the presence of thrombin and or the fibrinopeptide A cleaving enzyme batroxovan, that in these cases, neonatal clots are significantly less stiff, and they form weaker clots compared to adult groups. And this is seen with lower clotability, as well as faster degradation times and decreased clot stiffness compared to adult samples. However, what we found very interesting was that when we drive polymerization with fibrinopeptide B cleavage, we see significantly stiffer clots in the neonatal group. They also had greater clotability, and their degradation rates were not statistically different from adult groups. So taken together with the structural results, we believe this data indicates that neonatal fibrin polymerization involves more B-knob mediated interactions than adult fibrinogen, which is predominantly driven through A-knob interactions. So to further test these results, we also performed a competitive binding assay where we added high concentrations of fibrin knob mimicking peptides prior to clot polymerization. And these knob mimicking peptides bind to fibrin holes and block interactions during polymerization. So this is basically just a validation of our prior experiments. And here what we found is that when we incubate with a non-binding control peptide prior to polymerization, we see normal structural patterns with minimal effect from the non-binding peptide. However, when we add excess A-knob peptide, adult networks are unable to form robust clots, which is consistent with prior studies showing that adult networks are predominantly driven through AA interactions. However, neonatal networks are still able to form and appear pretty similar to controls, indicating that AA interactions are not as important for neonatal clot formation. However, with excess B-knob peptide, adult networks are able to form and they appear mostly normal, except for they're a little bit more porous. Conversely, neonatal clots are extraordinarily weak and didn't form robust networks in the presence of the B-knob peptide. So these results further indicate that neonatal fibrin polymerization is predominantly dependent on B-knob interactions, definitely to a greater degree than adult fibrinogen. So to further evaluate the role of fibrinopeptide release, we next quantified the release of fibrinopeptides via ELISA over a 2-hour clotting period, and then graphed the results as neonate over adult fold change. And in this graph, you can see fibrinopeptide B release in orange and fibrinopeptide A release in purple. And the reason that we were looking at this is because we wanted to investigate whether or not release dynamics were also different between neonates and adults. And what you can see here is that we observed that neonates are releasing less fibrinopeptide A and more fibrinopeptide B compared to adults. And this is particularly evident 60 minutes after initiation of polymerization and onward. Next, to determine the influence of sialic acid on these processes, we repeated this experiment with decylated adult and neonatal fibrinogen. And interestingly, after removing sialic acid, the ratio of neonate to adult fibrinopeptide A release is pretty consistently around 1 during polymerization. And there are statistical differences between normal and decylated fibrinogen in the later time points. Looking at fibrinopeptide B release in the decylated fibrinogen, we also see that the fold change between neonates and adults is decreased to approximately 1. However, these results were not statistically significant in this case. But overall, these studies demonstrate that neonatal fibrinogen, again, involves more B and less A-knob mediated interactions. and that increased sialic acid content of adult fibrinogen could potentially be, is likely influencing these trends. Lastly, let me go back. Lastly, we wanted to determine if we could recapitulate normal neonatal fibrin properties in adults by adding sialic acid to adult fibrinogen. And in order to do this, we used a silyl transferase enzyme with an excess of sialic acid as a substrate in order to add additional sialic acid residues to adult fibrinogen. Shown here are quantification of the adult fibrinogen with sialic acid added. And so you can see we can get to levels that are close to what we observed in neonatal fibrinogen. Then we polymerize the adult fibrinogen with increased sialic acid and analyze structure. And we found that that the clots formed from adult fibrinogen with added sialic acid have a structure that is more similar in terms of alignment and fiber density to neonatal clots than to normal adult clots. And so finally, we wanted to determine if we could potentially use this modified adult fibrinogen to treat or augment clot formation post-cardiopulmonary bypass in neonates. And so in order to do this, we took plasma samples from post-CPB neonatal patients, and then we added in either normal adult, purified neonatal, or adult fibrinogen with added sialic acid. And then we compared this to just normal transfusion or samples collected post-transfusion and using confocal microscopy. And what you can see here is that the addition of neonatal fibrin results in a uniform clot. And when we add adult fibrinogen with increased sialic acid content, we get clots that look fairly similar. We also assessed functionality of these therapeutics by looking at clot degradation and found that the sialylated adult fibrin significantly slows degradation after cardiopulmonary bypass, but has rates that are more similar to what's seen in. It's closer to the rates that we see when we add neonatal fibrinogen to the post-CPB samples. And these results demonstrate that modulation of adult sialic acid and fibrinogen could potentially be a feasible method in the future and a potential target for therapeutics for treating bleeding in neonates post-CPB. And then just very quickly, I want to point out that we've also been investigating the role of increased sialic acid and neonatal fibrinogen on wound healing outcomes after cessation of bleeding. So here we've formed fibrin networks from adult and neonatal fibrinogen, and we've looked at fibroblast attachment. And what we see is that normal neonatal fibrin actually promotes enhanced fibroblast attachment compared to adult fibrin. But when you remove the sialic acid from the fibrin and then plate fibroblast, we no longer see differences in attachment, indicating that the sialic acid could be promoting enhanced wound healing after cessation of bleeding. And I won't go into the details here, but we've been interested in investigating this just because we've shown recently that fibroblast spreading and migration through neonatal fibrin networks has increased compared to adult networks. And then also, if you take neonatal fibrin clots and then apply them to wounds on the back, full thickness dermal wounds on adult mice, you can actually observe an acceleration in wound healing outcomes compared to mice that are treated with adult fibrin. And so with that, I'll conclude. I won't read all of these in the interest of time, but I'll just point out that just to summarize, the fetal fibrinogen present in neonates creates an altered fibrin network, and we've shown that this can have implications in treating bleeding as well as potential thrombotic risk in these patients when they undergo cardiopulmonary bypass. And we've shown that increased sialic acid content could be a key contributor to the responses. And so with that, I'll just end by thanking predominantly Kim Nellenbach, who was an just outstanding PhD student in my lab who recently defended, as well as my collaborators at Emory and Choa, Nina Gazzetta and Laura Downey, and of course funding sources and you for your attention. And so I'm happy to take any questions as time allows.
Ashley, it's Ed Conway.
Oh, hi.
Hi. That was fantastic. It's really nice to see people working on pediatric-related bleeding disorders in that manner. I have a bunch of questions, but I'm going to bundle it. First, age-dependent differences, truly like from encylation of fibrinogen from young to old. 2, sex-dependent differences. And 3, are there inherited disorders of cyalation of fibrinogen to explain bleeding disorders?
Yeah, that is an outstanding question. And I will say it's something that we really are interested in looking at. But at this point, we've only kind of started going down this route the last couple of years. And so our initial patient samples have been really limited to that neonatal period, just in the first 30 days. We've recently started doing some studies looking at differences between cord blood, fibrinogen that we're getting from cord blood compared to, collected actually in the neonatal period. And there does seem to be some differences in the amount of cyalic acid that is, even within those first 30 days. But at this point, our patient sample numbers are they're so low that, we can't make really strong conclusions. And so we're hoping moving forward to start collecting patient samples from a larger patient population.
Sex-dependent differences?
Yep, sex-dependent differences. We also have not, we haven't specifically looked at that yet.
The cord, won't that be transplacental? Won't that be from maternal fibrinogen that you're collecting?
Yeah, so that's a really good question. We have recently gotten cord blood from a commercial source, and they indicated that that it was not contaminated with maternal, because that was also a concern of ours. Interestingly, the cyalic acid in the cord blood is a good bit higher even than in the neonatal period.
Okay. Other questions? Ed Prysdale must have questions. Come on.
I've got a question.
Okay, Dana.
Yeah, so I'm a little bit curious about this whole idea where this problem initially starts with pump priming for the cardiopulmonary bypass pumps, and I'm just wondering why, with the widespread availability of whole blood in the U.S., why are people not priming the pump with blood?
Yeah, that's a good question, and one that I don't actually have a good answer to. I'm sure if my clinical collaborators were here, they could answer that question for you. I'm not sure if it has something to do with potential thrombosis, but off the top of my head, I'm not 100% sure.
Okay, thanks. And then I have a second question, which is what do you think is the sort of the ontological benefit to the fetus of having a fibrinogen molecule which behaves differently from adult fibrinogen? I mean, I think we understand that for hemoglobin, but this is an interesting difference.
Yeah, I mean, it's a really good question. I mean, I think it's not just fibrinogen, right? Like there are a number of clotting factors that are both qualitatively as well as quantitatively different in the neonate compared to the adult. And all of these factors, in a healthy neonate balance and in the closed system, and you don't typically hear about a lot of bleeding babies. It's just when in really sick children that have their coagulation system thrown off by CPB or other reasons, that's when we really see the manifestations of these bleeding problems. Now, why? What are the actual benefits? I presume it's to potentially decrease the likelihood of thrombosis in utero. That would be my my guess, but I don't know that it's precisely been pinned down.
Do you think it's in utero or is it during the delivery?
I think it certainly could be both.
Yeah. Okay. Are there you guys have other questions down here?
Yeah, Ashley, that was a great talk. This is Ed Prysdale. I have two questions, really. The first thing, I'm not sure how you induced clot formation, but I'm wondering if neonatal thrombin may recognize neonatal fibrinogen differently than adult fibrinogen.
Yeah, that's a fantastic question, and one that we have not, that we haven't really explored. So we have taken a lot of care to just use, certainly just use neonatal fibrinogen, but we have, in most of our clot, we induce clotting by adding a small amount of thrombin, and typically we use adult thrombin. We have not explored how there might be differences if we were to use neonatal specific thrombin,
Yep.
But that is an outstanding point.
It could be very cool. I'm also wondering if you might elaborate a tiny bit on why a neonate might want to clot a little bit differently than an adult.
Sure. So, that was something that we were just chatting about, I think, during the last question. And I think that there could be a number of reasons why a neonate would clot slightly differently than an adult. I mean, overall, they're less, they clot less, and I think that it could just be due to if there's potential trauma, as we were just describing, if there's trauma during birth, or having decreased potential for clotting could be good from that point of view. And those are the things that come to the top of my head right off the bat.
You have another one, Ed?
That sounds good. Maybe I could ask you another question from my colleague and collaborator, Mark Billatrudi writes in. He asks, he states, great presentation, and he says that we know that platelet transfusions don't always stop bleeding in neonates, likely for these mechanisms. What's the next step for better clinical management? Have you got some thoughts on that?
Yeah, that's a great question. So, I didn't even touch on the platelet side of things, but even, based on our work, we certainly would expect that transfusion of adult platelets are likely going to have different interactions with the neonatal fibrinogen that's present. So I'm sure that that is playing a large role, and it's something that my colleague Laura Downey is currently very interested in pursuing, looking at the role of platelets. Of course, when you are also transfusing platelets and adult fibrinogen component, that could overcome those potential deficiencies, but then you're likely swinging the pendulum more towards thrombotic complications in the patients. And so the way that I've really been thinking about it, and my colleagues at Emory and Cho have really been thinking about it, is more in terms of how can we have a more neonatal-like clot forming. And so I didn't present this work today, but some of the in vitro, or I guess ex vivo work that we've done has also been looking at the use of other procoagulants in neonates that act more upstream. So can we give things like factor 7 that are going to, jumpstart the neonatal coagulation cascade, as opposed to just giving a bunch of fibrinogen, which would, rather than giving a bunch of adult fibrinogen, which would be, kind of overriding the neonatal clotting cascade. And so in general, I think if we can think of ways to better promote more neonatal-like clot formation, that's going to improve treatment and decrease thrombotic risk in these patients.
Thank you very much, Dr. Brown.